So thank you so much, Dr. Metz. We really appreciate your support of this community. I'd just like to ask our panelists if you can come up to the front and just leave the seat closest to me free for Chris. So we're going to have a panel now just talking about this next step of how do we kind of think we could build a multidisciplinary center of excellence within Southern Alberta to help people with hypermobile conditions. We did solicit a lot of questions in advance, so thank you for those of you who had a question during the registration process. We had over 400 questions, so of course, we're not going to be able to answer all of them, and not all of them are related to this specific topic of the panel. So you've met a lot of the other keynote speakers earlier, and I would now like to introduce Chris. So Chris Lamarca is a former high school teacher with multiple health conditions, EDS being at the center of these challenges. Managing their health is now their full-time job, and they've learned many lessons along the way, and they'll be providing a perspective of a patient. Rebecca Margel is a registered physiotherapist with a special interest in joint hypermobility and connective tissue disorders. Over the past 4 years, Rebecca has worked extensively with this patient population, developing a compassionate and evidence-informed approach that emphasizes the whole person care and sustainable movement strategies. She holds a Master of Science in Physiotherapy and a Bachelor's of Science. So I have a series of questions which will be targeted towards specific panelists, but of course, if someone else wants to add anything, please go ahead. So we'll start with Chris, if maybe we can pull the chairs out and just pass you the microphone, make things easier. Okay, so I was hoping if you could just kind of share with the audience, like not everyone here is a patient. We have family members, clinicians, researchers, politician. Can you speak about what your experience is navigating what we might call fragmented care with a complex chronic condition might be, seeing different types of providers in different places?
So that is one of the most, I'm just going to help you here. Now, can you hear me? There we go. So that's actually one of the most complicated things. Most of us do not just have EDS or hypomobility. Most of us have pretty extensive care teams because we have multiple diagnoses, but often at the center of that is hypermobility. So we are seeing a lot of different people, and one of the biggest things is a lot of those people don't communicate with each other for various reasons. One of the things is like EMS, they don't have access to Netcare. So they can't see what your medical conditions are, which is why I've created, actually very similar to the chart we were talking about earlier, a chart that I can hand to them. That's also the same chart that I give to every one of my doctors. Dr. Minocha can attest to, I come to my appointments very well prepared. I come with pictures, I come with videos, I come with charts and exactly what I want to accomplish out of every appointment because everything is so disconnected. So for me, I have to be the person who is super organized, and I'm giving that same sheet to each of the different doctors because they may never talk to each other, but several of them are like, oh, I'm going to put this on Netcare. I've created my own unique pain scale for myself, right? These things are things that I can do that can kind of coordinate that, but it is so disconnected. So, I'm very glad to hear that MLA Metz was talking about this disconnect and that they understand that it's there and working towards a teams model because that is what we need. We also have this problem where a lot of specialists do not put their notes in Netcare in a timely manner. So sometimes it could be 6 months that you're waiting for notes to get to your GP so your GP can figure out how to change a medication, how to do whatever it is that needs to be done. And another thing there is private clinics versus public hospitals. So when you're in a private clinic, they don't necessarily have access to all the same things and vice versa. So if you go to Sierra or Endo and they have all their notes, those notes may not be on Netcare. So unless they send them to your GP, again, there's that huge disconnect.
Thanks, Chris. And Rebecca, right now you're working in sort of a small community clinic and you're the sole provider with expertise in hypermobility. So can you talk about, as a practitioner in that role, what some of the challenges of just being the only one there is like?
Yeah, so it's a great segue from what Chris was just speaking about. So So I feel very siloed and isolated, and I do my best to try to manage that by connecting with providers any way I can. So I think I got connected to Dr. Minosha. I think I put my phone number on the bottom of a fax regarding a patient instead, like, I exist, call me. And so sometimes it's easier, sometimes it's a bit more challenging, and it's a lot of work. But just trying to maintain some sort of connection. I can't see your Net Care, I can't see Connect Care, but I can at least try to have some FaceTime with the other providers that exist out there that are treating patients with these conditions. And so, but it still is very isolating, and it can be really challenging. You kind of feel like you're getting a bit of a runaround trying to advocate for your patients as well.
Thank you. Yeah. And Dr. Cohen-Solomon, you've worked in a few different locations and types of practices, and right now you are working in sort of a specialized clinic focused on hypermobility. So can you talk a bit about what you've seen that works well in that sort of a clinic setting?
So first of all, we do need to start with a willingness. That is obviously up to the individual. And systemically, physicians of all sorts, clinicians, are not given enough appropriate time to accomplish administrative work. So that has to be at a larger systemic level as a fix, legislatively as well, making sure there are appropriate resources so that care coordination has time appropriately, because otherwise we end up with overburdening of the physicians and burnout, and that's not good either for us or for you. But one major point is that any multidisciplinary care clinic will have something to learn from any other multidisciplinary care clinic. The medical home model, in which there's somebody steering the ship who isn't the parent, is a great place to start, because the parent should be the parent, not also the primary care clinician. Did someone try to clap for that? Thank you. I don't know if it was intentional or not, but yes, that's really, really important. That's actually, that is my impetus for doing this, because my mother was that role. And without spilling emotions, I would not be here without that effort by my mother. So clapping for the mothers and the parents of all sorts, the people doing the work as caregivers, cannot be emphasized enough. The clinicians all need to be willing to communicate with those people too, because as a pediatrician, it's not just about communicating with the patient in front of me. I need to listen to and communicate with the entire team taking care of this child. So it becomes sort of a rings around the central issue structure. Also, this is just a bit of a side point, but if anyone is ever able to donate some of their precious energy and time to medical schools to be one of the patients who are sitting in front of classrooms like this to say, hey, this is my life experience, please learn from it. Most medical schools have models available for that, and it's often a way to kind of get in early so that those people learning to become physicians learn how important these things are and hear it early and often. But they need to hear that these are not, that the individual condition might be rare depending on the specific diagnosis, but rare conditions in general are not rare. And if we don't hear that early, we won't think of it later. Mm-hmm. So, my email and phone number is always available for other clinicians to communicate with, and just being willing to do that in the first place, enormous difference.
Awesome. And the clinic that you're in right now, can you just explain what that looks like? What kind of practitioners are there?
Yeah.
Does a patient just see you one time? How does that work?
So first and foremost, we are brand new and very much, this is 100% intentional pun. We are looking to be flexible with how we build it so that it works. Because we're always going to find new barriers that we didn't know existed until we tried to do something. And then our entire goal is to make this work well for all of us, for all of you. And if we insist it looks a certain way, we might not get there. So flexibility. But the intention, first and foremost, is that almost every clinic that exists at this time in an academic center is what's called a tertiary clinic. So you go for a diagnosis and maybe a small amount of specialist care, but the intention is not complete follow-up and to be followed long-term. That is an enormous barrier. And so the reason I joined this clinic is that is not what we have in mind. We have in mind a medical home, not necessarily that we are the primary care or the GP, but that we're working hand in hand with that individual to manage and coordinate your care long-term with appropriate follow-up. So at this point, we have 4 clinicians, 3 physicians, and 1 amazing nurse practitioner. Our medical director is Dacre Knight, who previously was at Mayo Clinic and looked at the wonderful things that they did and the things that he wishes that they did, and now he's bringing it to us, so we're very lucky to have him. Ina Stevens is our associate director. She's been single-handedly caring for patients like this in her integrative medicine clinic for many years, so she brings a very complete, very thorough background and knowledge to that. Myself, we've already heard about me, and then Angie is our nurse practitioner, really brilliant and experienced, and we are about to hire another advanced care practitioner to kind of complete the starting point of initial diagnosis, but also please don't hesitate to come if you already have a diagnosis, because again, care coordination. We're going to be integrating appropriate physical therapy and occupational therapy. We're working on how that format's gonna look. We are currently hiring, please apply, for a dietitian. We're also hiring a pain psychologist, and if anybody is worried about that because the internet got worried that we put that online and everyone went, oh gosh, do they think this is all in your head? No, that's not why we're hiring a pain psychologist. We are hiring a pain psychologist because this is hard to deal with, and we want to make sure that we give everyone every tool we possibly can. And by the way, every single prescriber in the group manages pain to some degree, so we're not ignoring the pharmaceutical aspect or the prescription aspect of that either, so please don't worry. And we are going to be expanding as quickly and as appropriately as we can. We want to make sure that every move we make is sustainable, so we don't want to go too far too fast, but as thoughtfully as possible. So I really believe in the people who I am joining, and I'm going to stop because I could just keep going. Yeah.
Go ahead, Maggie.
She neglected to mention there's a patient advisory group. So every decision that's made, every procedure that's introduced, everything that's going on in this clinic is run by a group of people with lived experience.
Thank you. That is extremely important, and another reason why I really believe in this, because each and every person who's on the care side understands the value of the lived experience above all else. So, and we are going to be doing research, and I swear I'll stop now. Yeah.
That's great. And you reminded me in all those opening remarks when I was reading through everything, I forgot to mention that patients were also involved in planning this event. So thank you to those of you who helped, both formally and informally based on feedback from prior years. So now we'll move to Dr. Gilmour. You actually achieved this dream. You started a multidisciplinary clinic for people with functional neurologic disorders. So I was hoping you can just share your experience of what that was like, what was involved with that and how it's gone for you.
Yeah, I'll start off by saying I don't know, achieved. It's like it's a constant work in progress, and we're constantly trying to continue improving the level of integration. So I started our program at South Health Campus just a couple of years ago, and I was very privileged to learn from a really great group in Toronto that I had mentioned during my talk and see how they built an integrated clinic where in one room with our patient, we have multiple different care providers. And so I personally love that because I love that I get to learn so much from the people I work with. I think that it's great for our patients because then they don't need to repeat their story 1,000 times as they meet all these different people. And so that was kind of the idea in how we built that. It actually was much easier to get approved than I expected because it's less resource intensive to only require one room for a big group of clinicians as opposed to different rooms for all of them. It's easier to book because you have one patient being booked in to one appointment essentially. So it actually ended up being, from an administrative side, easier. And it was an unexpected, easy thing for me to get approved from our division at least. And what else can I tell you about that?
Maybe who's in your clinic?
Yeah, sure.
And I guess just the logistics of it. Sometimes it can be hard to get all those different types of practitioners together. How are you able to do that?
Yeah, so in our clinic, so in the assessments that I am in, we have myself, the neurologist. I work with 2 different neuropsychiatrists, and so they're coming very much from a sort of, how does our brain affect our body, and how does our body and brain affect our mental health, and integrating all of those pieces together. And then we have our nurse who's incredible and acts very much in sort of a care coordination role. And so it's really important for her to be in those meetings with our patients as well, because then, again, when somebody calls, they're not starting from nowhere. They're hopefully starting from having met each other and, sharing that story together. So that's our initial visits. And then in terms of the rehab team that I work with, they have built a program that's also sort of interdisciplinary, where they're kind of passing between each other patients throughout the day. And so there's a big group of them, and they kind of, work together very closely. And in terms of the challenges.
That's great. That's great, unless there's anything else you want to add. Perfect. So let's give it over to Maggie now. I guess you've had a lot of experience, decades of experience as a patient advocate. What's your experience with starting and maintaining sustainable multidisciplinary clinics in that role?
As an advocate, I encourage, if there's an interested doctor or clinician or whatever, I encourage them to just have one day to begin with, where they bring in multiple patients so that they are thinking in that rare space, in that column of things to consider. It's all one day of the month in their practice. And then build their network or collect the names and information and contact information of people who are likewise familiar with these diagnoses related to hypermobility that can provide services in their community, and build up from there. So it starts as a center where they're referring out, it builds upon that, and then they might have a day where they are communicating and reviewing multiple cases with that network. And it can be done efficiently, it can be done virtually, it can be done in person, but it's a place to start, especially in a rural community or in a hard-to-reach area where you don't have access to a medical school clinic.
Mm-hmm. And go ahead.
Well, I want to build off of that, because I think I always like everything Maggie has to say. If you as a clinician are doing something of that structured sort, it can be a little easier to build in that time to communicate with the other clinicians who might become your network, or I almost think of it as a spider web half the time, because they know that that's the day that you have available and that you can build in some time to do that communication. So connecting Maggie's remark with Dr. Gilmour's remark, the importance of the who do I call for this, the who can my patient trust with this, it can't be overstated, being able to work with appropriate other people, experienced and knowledgeable, as well as respectful. So.
Yeah, thank you. So as we saw at the beginning, probably around 70-75% of people here are patients. So what can patients do to help advance this vision forward? A lot of the questions in the Slido, we're talking about, it takes 3+ years to see someone. We know in Calgary, a lot of rheumatologists are not accepting patients. My clinic's been closed to new referrals for 1.5 years just to manage the workload, and we're still working through those 3.5 years worth of patients to be seen. So what can patients do to kind of try to support this?
First, be open and willing to collaborate with your primary care provider. Give them grace, give them space, give them the opportunity to say no and later change their mind. So that's our headspace. We want to welcome them into our community rather than push them into our community. And we're going to get a lot more done that way. Increasing awareness, volunteering, as I said earlier, for a lunch and learn in your local clinic or your local healthcare facility. If you show up with food, they will listen. It's a tried and true formula. And make sure that you send thank you notes, follow up. If you need some ideas of how to do that creatively, see Catherine. She lives in this area. She does that regularly. And network and connect with other people with lived experience in your area. Clinicians, I would encourage you to be just as curious and ask questions and recruit an active person with lived experience to help you craft something, anything that's supportive for this community. Because the people here, the 70% of the audience here are people with lived experience with hypermobility. They're looking for anything. They're looking for acknowledgement. And that addresses a psychological and mental health burden that many of the people here won't talk about. Just the fact that they're here and there's somebody who says, yes, I understand and I believe you, relieves a great weight for many of these people here.
Thank you. So Rebecca, I was wondering if you would be comfortable sharing, like, how would the existence of a multidisciplinary clinic in Calgary change how you practice as an outpatient physiotherapist?
I think a big challenge that I didn't mention earlier is the accessibility piece. And because so many of the professionals and the doctors that patients want to see are inaccessible, patients will end up in my clinic and I'm their first point of contact of someone who knows anything about hypermobility. I'm a private practice physio. I don't have access to like an established network. And so I think that having a clinic that is accepting patients and that can provide care that can collaborate with us. Like at the end of the day, if it's in Calgary, so much of the community lives in Brooks and Medicine Hat and Okotoks. It's not going to be accessible to everybody, and it's still going to come down to patients needing to see their small local outpatient physiotherapist clinic. And so I think if there was some sort of like group where we could all connect and talk about challenging cases and figure out where the appropriate referral is. I think I waste a lot of people's time and money sending referrals where it's like a shot in the dark. You're like, I don't know, this guy's a neurologist. I'll just reach out to him and it's maybe not the right person. It gets bounced back. So having a coordinated something that connects to community physios, like, yes, we're private practice. That's the way that our system works, for better or for worse. And so really having that bridge between the clinic and any outpatient providers and family doctors, because I think they can feel quite isolated as well, where we can maybe connect with each other and discuss challenging cases and where it's appropriate to refer people or what we might try that we haven't already tried in a way that's accessible and local to them, I think would be really, really beneficial.
Yeah, thanks. It looked like you were going to say something.
So the Ehlers-Danlos Society does have an ECHO course where clinicians can do drop-in hours. So some of the best clinicians in the world will take time it's usually 12 p.m. Eastern Standard Time, so obviously not always convenient, but they will have different sessions available for different time zones periodically. And it's really, they discuss challenging cases and will take questions on how do I do this for my patient from the audience, essentially. And it's tremendously valuable. At UVA, we are planning on having case conferences of that variety. If anyone's familiar with what's called tumor boards, at least in the U.S., it's essentially a group of specialists who will review patient cases for the appropriate way forward for that individual with various types of tumors. And obviously, the importance of that was very, very obvious in that patient population. And we are trying to learn from that extremely important approach to get everyone in the room at the same time a couple of times a year to learn from each other and to discuss the best way forward. And that is where progress happens. And the very last thing I'll say on that subject is that legislatively, we need options for video or telemedicine across state lines and, by God, across countries.
Thank you. I'll just quickly add that in Calgary, there's a group of about probably 11 physicians across pediatric and adults caring for different aspects of people living with HSD and associated conditions, including cardiology, gastroenterology, physiatry. So we are working towards building something, but like you're saying, the first step was getting everyone in a room together. So we're trying to meet up every 3 to 4 months for dinner. Each person is kind of presenting general approach to XYZ, to POTS, to managing joint instability, what have you. And now as a group, we're starting to discuss care pathways for the province. And so that might help family physicians and other primary care providers at least know where to start, because we know it's going to take a while to build a clinic. Like you were saying, we can't just have a clinic in Calgary. What about everyone who lives outside of Calgary? So I think there's some truth to that. We're trying to do our best, get everyone in the same room. Chris, I guess for you and your experience as a patient, I see you taking notes, so feel free to diverge off the question, but how do you think having sort of one place where you could access care would help you as a patient?
I think everyone in this room knows that would be completely life-changing. That's one of the things. So one of my roles is I'm a patient partner with SATE. I do I run some support groups, that kind of stuff. So I talk to a lot of you guys, and the same things come up. There is, why would I get a diagnosis? How do I get a diagnosis? And what's the point of getting a diagnosis? They're all sort of interrelated questions of, even if I get a diagnosis, I'm dropped. So a lot of times you get a referral to a specialist. That specialist is hugely overworked, overbooked, and they can usually give you about 3 sessions with them, right? So you go in 3 times. At the end of that, you're left and you don't have follow-up. So you are trying to piece it all together yourself. All of my care, pretty much, I've pieced together myself. I found a physiotherapist that was knowledgeable in both EDS and FND, because I have FND as well. I found a psychologist that could help me with FND, a different psychologist that could help me with trauma. So I pieced all of my things together. Having a place where you could go where everything was just there would be incredible. So I posed the question to one of my groups, and the things that they said was, it would be amazing to have long-term care, so not that dropped after a few sessions, because it feels like being broken up with. Can you guys relate to that? Where it's like, you're like, oh, I have this really great rapport with this doctor and this is awesome. And then they're like, I'm going to release you to your GP. And you're like, oh, this hurts worse than the boyfriend who broke up with me in high school, right? Because it feels literally like a breakup or worse, right? So another thing is, people are really looking for the diagnosis being on net care. So when you walk into the ER, if you have to go to the ER, if there is a lovely place where you can go instead of the ER, that would be amazing. Because the ER is not a place to be when you have hypermobility. No, right? You sometimes luck out and you get an amazing doctor. And if you go there enough, they get to know you and they're like, oh, okay, I know what's going on. We know what to do. And it's an easy process. But if you're going somewhere different, that ER experience can be so disheartening. I have talked to so many people, myself included in this, who have been suicidal after going to the ER because we are gaslit and we are told we are drug seeking, or that pain is in our head, or I can't see that on a scan. Your blood work looks fine, right? We have all heard those things. I see lots of nods. And so having a place that, first of all, we don't have to start at the beginning. We don't have to say, I have EDS. I have a connective tissue disease. And they're like, what's that? Or some doctors, I don't believe that exists. POTS isn't real, right? So if we went to a place where we just from the start were believed, how amazing would that be? And then could focus on things like pain relief. What are our goals specifically? If we could come in, have an intake meeting, that idea of walking in, sitting at a table with a bunch of different practitioners and going, this is what's going on, these are my needs, and them going, okay, I have physio for that, I have a psychologist for that, right? And having a full team would be absolutely amazing. Access to care without financial burden is something I hear all the time. I am personally incredibly lucky. I was a high school teacher. We tried many times to get me back to work. I have other life-threatening medical conditions. I tried 3 times, couldn't work. Eventually were like, you have to think about your students. What happens if you have a medical emergency in front of your students? I was like, okay, gotcha. But there's a huge financial burden, and I'm lucky that I have enough support to get my walkers, to get all the things. But if there was somewhere that you could go and they could help you with applying for aids for daily living, applying for disability, applying for the disability tax credit, talking about those things, because that's a huge barrier. And that's where the difference in care for people comes, is it's a huge financial burden. Being disabled is expensive when you can't make much money. Another thing was having one-stop shopping. So if there was a place that had cardio, physio, physiatry, chiro, gastro, dietitian, geneticist, orthocist, could you imagine? Like, that would be amazing. If I could go get my braces at the same place that the doctor diagnosed me at, completely life-changing for us. And one of the things is this is actually way more cost-effective, and this was already alluded to. If we could just walk into a place and not have to have 100 referrals being bounced around and it taking years, diagnosis would be quicker, we'd have less injuries, we wouldn't have to go to the ER as much. So if the government's listening, it would make a massive difference. I know the NDP is listening. I love NDP. They're listening. The other thing was a better understanding of comorbidities. I keep hearing this over and over because it's not just one thing. Like, we all know that little lovely trifecta with mast cell and POTS, but there's lots of other things too, things people aren't necessarily thinking about. Your dental care, right? Or arthritis, osteoarthritis, osteoporosis, all of these things, right? They're all interconnected. And the use of patient partners is huge. All of this should be influenced by what we as patients say are our needs. Because all of us have been told by some doctor, well-meaning or not, what our needs are, whether they're actually what we need or not. So having all of this in one place would be absolutely incredible for us.
Thank you. Go ahead.
I hope it's okay that I share this, but ICD codes, can I talk about that?
Yeah, please.
Okay. So when you see your family doctor or your specialist, asking them to use whatever the hypermobility or EDS ICD codes are, that is the way that your physician is invoicing the government. And so they have to tell the government what they've treated you for, what condition you have, and it's like a numbered code. If your family doctor, maybe you're coming in with migraine, maybe they're putting the migraine ICD code, but you have EDS ICD code, because that allows the government to collect data on how much of a problem this is. This isn't a super rare disease. We have 600 people, presumably from Calgary, just attending this day. So if everybody is getting this, their family doctors to document this, that hopefully that data can be pulled somehow and to demonstrate that we need funding for clinic, and maybe not just a clinic like this, but several clinics like this.
I'll just build on that. So that is really helpful. The code is actually benign joint hypermobility syndrome because these codes are very old, but you can have more than one diagnostic code, and it is helpful because really what helps shift things is money. And if we can show that, if your people are going to the emergency department because they have a medical home, or if we can show this is actually the number of people seeing these kinds of specialists, that can help build the case. And so it has been messy and hard to track. So I would just echo that both as the clinician and the researcher here, that does make a big difference. Go ahead.
There is no specific code for hypermobile spectrum disorder, and there are no specific codes for the new framework for pediatrics that falls under HSD, which creates an enormous problem with, as you say, finance, and an even bigger problem with research, because if we are researching based on outdated terminology, what we're getting is a mess. So our research data is a mess. And we can't change that without proving that we need to change that. So we're very much stuck in a loop. And it's a big old problem. And just for the sake of humor, you've never seen a more shocked face than the MA, the medical assistant who doesn't know how to find hypermobile Ehlers-Danlos syndrome in the system, to which I handed her the code. It's Q79.62. So that was a fun day as a patient side of things. But they didn't know that. They'd never used that code before. So little knowledge goes a long way.
Yeah, and like I said, you can have multiple codes, and it is helpful to show this is how many people have both, for example, migraine, headache, and joint hypermobility.
And you can document the symptoms as ICD codes, which actually is very helpful. Mm-hmm. Please be diligent, for any clinicians listening, please be diligent in not doing it wrong. The first thing that pops up whenever I type in dysautonomia is the wrong dysautonomia, and it is a very specifically, importantly wrong dysautonomia. So you can say chronic pain, you can say specific areas of chronic pain, you can say orthostatic intolerance. By the way, POTS has its own diagnosis code, thank goodness, as of about 2 years ago. That's G90.A. But if we are, lazy in our coding, we get lazy data. So we have to be diligent. And that's hard. That's really, really hard. We're tired by the time we're putting those in. But the more data we can collect, the better data we'll get from that.
Go ahead, Maggie.
I'll put a plug for FND as a diagnostic code as well. It's also available and really helpful if in Connect Care, if you're in Alberta, that you include that in the problem list.
But not if you're guessing. If you're a clinician who knows what they're doing, like Dr. Gilmour, please put it in, but please don't put it in if you're just guessing.
I think also just quickly from a patient advocacy standpoint, I think hearing a lot of the suggestions from Maggie might have been maybe overwhelming for some people who have no spoons to give. This is a very low spoon way to feel like you're advocating for yourself. Okay, go ahead.
And be prepared for more codes to come through in coming years. Remember, the Ehlers-Danlos classifications will be updated later this year, and then there's a lag time of 2 to 5 years before the codes are updated.
But you can write that in your note, even if the code is outdated. You write, and I cannot actually emphasize this enough, because you won't get, as a clinician, if you're putting in an outdated code, you're in the States, insurance won't then cover whatever you want for that. But if you write the wrong code and say, this is the closest we have because the code doesn't exist, one, that's an advocacy point. Two, they should look at that and reimburse appropriately. And all of that has downstream effect on how we can treat and learn about patients.
Fantastic.
I'm done now, I promise.
I think, unfortunately, we're going to have to wrap the panel up there, but our panelists are here to chat with you after. Dr. Metz will be here to chat with you after. So thank you so much.